Great. Welcome, everybody. My name is Bob Wiseman, chair of the 4th Digital Transformation in Government Conference. And today we have the distinct pleasure of welcoming Alec Blair from the Alberta Health Systems. And he's going to talk about how you can basically use information systems as a catalyst for business transformation. So without further ado, I'm very much looking forward to your presentation, and it's over to you, Alec.
Thanks, Bob. You forgot to mention that you and I have been interacting off and on here for probably the better part of a decade. And so it's a pleasure to be here out of the persona that we normally interact with. So thank you very much. I hope the conference has been going well. I'm going to do my best to speak. I do have the chat window open. If you have a question or a comment that you'd like to put, please feel free to put in a chat message, or I don't know. I guess you're being moderated. Sorry, the moderator will forward those on.
Exactly what's happening is that if you have any questions, please put them in the Q&A. And yes, Alec and I have been had the pleasure of working together off and on for the last 10 years with the Open Group.
Yeah.
And working in business architecture, information architecture, and all sorts of things architecture.
Right.
So I'll over to you. And if you have any questions, please put them in the Q&A and I'll pose them. Alec will be speaking. We'll have about 10-15 minutes after the presentation to do that. Thank you.
Sure. Thank you.
Thank you.
You know, I always, whenever I try to present myself, especially when it's to an audience that's outside of Alberta, I try to put some things in context. But in this situation, I also wanted to put some things in context for myself. And when Robert sent me the theme that we were looking at digital transformation, and I was thinking about how should I explain some of the experiences that I've had and where I've gotten to and what I've done, I thought I'd put just this is a random pick of things that I was able to go and search and find. When was the earliest media thing that happened around a specific set of some form of emerging technology or some transformational technology, or in the case of Y2K, some form of disastrous technology potential in there. And I kind of laughed as I looked at the list, partly because I've been doing this way too long, it seems. But I used to be on the product side of the fence, where System House and Fujitsu, where I was on the application and technology infrastructure side of things with System House on the data center side and outsourcing. And then I moved to Fujitsu more on the ERP custom application dev and business intelligence. And I remember as a marketing campaign using some of the emerging technologies that are coming out as certainly a sales technique and tactic to try and get our customers to get on leading edge, bleeding edge, or anything else. And I kind of laugh as I look at that, and I look at some of these things like DevOps that theoretically came into vernacular in 2009, and you've got a lag time between sometimes when things get introduced and people actually know what and how they're going to use some of these things. So I think, when you think about government organizations, and certainly for me working that in the last 13 years with Alberta Health Services, which is a pseudo-government organization, we have a lot of interesting responsibilities and legacies and things like that. So it's I looked at the quotes that were going on from the website for this conference and saying that people were saying digital transformation is their number one concern, and all of these things. And I think, in my experience, what I'm hoping to be able to show you is that I'm not sure that digital transformation in and of itself is the reason why the 80% or 90% didn't actually develop and deliver the benefits that were anticipated. I think the biggest problem is that we're mispositioning what we're trying to do. If we actually think about what we're trying to do as a digital transformation, then I agree that you're not going to get the benefits, because it's almost a means. We're trying to put digital as the end unto itself, and I went into information technology because I saw information technology as a way to make people's lives better. And so that's why I said my key messages would be that it's a business transformation we're trying to encounter. if you don't start with the business and at front and center, and you're just trying to, take a technology and, tail wagging the dog, where can we go find this? Here's my solution. Where's the problem? I find that's invariably going to lead you down a path that's going to be unsuccessful, because you're missing the point for the organization, and you're missing the point a lot of times for the end users. And so I always say start with the business context. Now, I'll admit, I'm an enterprise architect and I'm a business architect. I've helped co-author many of the Open Group's papers and guides on business architecture. And so that's my lot in life. But I would say in general, I don't know that many people on the system side who wouldn't want to have an understanding of their users and the use cases and all of that kind of stuff. So start with the business context. And then the other thing is, don't underestimate the time dimension. I would say in my career as an architect, rarely is one thing standing all by itself, right? And so there's all these interdependencies that we have to understand, not the least of which is governance around actually implementing anything versus organizational change management. And so the time dimension is a key aspect of digital transformation that you have to think about, is, where are your plateaus and all that kind of fun stuff. And I'm going to go into this in a bit more in our presentation. And my last one is to the degree possible, be agile. The case study I'm going to go through is the antithesis of agile to some degree. I'll maybe call it an agile waterfall, but it's I found for especially leading edge digital technologies where we're able to be a little bit more agile and start with a proof of concept and expand is certainly the way that I would go. I like putting my key messages up front because I find hopefully you'll see whether or not I address all these points, so you can hold me accountable for that. But also I always tell my architects whenever they're presenting, especially to senior leaders or even anybody presenting to senior leaders, don't bury the lead, right? Don't go and say this is, wait 20 minutes in to say what your key messages are or what you're trying to actually get you to do. So these are my things that I hope that maybe you'll be able to see through my presentation, and we'll be able to reflect at the end to see whether or not that's still true or not. So I work for Alberta Health Services. We are a fairly large organization. I'll let you read the slide here. As an enterprise architect, this is quite the dream from trying to take something that's massively, massively complex into something that hopefully is streamlined over time. We were formed in 2008. I joined in 2010, and really in that intervening time, they really hadn't started any real serious initiatives to try and consolidate some things. But as an organization goes, we're providing care services to almost 4.5 million Albertans. We have 100,000 staff, 900 facilities. It's big, like we're just massive, and you can see some of the things that we do here. And so we're not unique anymore in Canada and having a provincial jurisdiction that runs everything. It's certainly different than Ontario and Quebec, and to a large degree, British Columbia. I think that is going to pay off some stupendous dividends going on, but it certainly is. When you look at the breadth of everything that we've got, it certainly raises some very interesting business problems. The first of it is we have to deliver care. We cannot obviously have, or we want to try to minimize to the biggest degree possible, where IT for sure would not allow patient care to be provided. And so we're having to do a lot of this. And so the amount of testing that we do, the amount of contingency planning we have to do is truly remarkable, and maybe larger than any of you may need to do given your areas of practice or your scope. I'll admit I'm coming from a very large organization by anybody's definition. The other thing that we have to consider is our geographic scope. We have our two major metro areas in Edmonton and Calgary, that is 2/3 of the province. And then we have our north zone, which is massively geographically diverse and with low population. And then as you go to the rest of the rural areas of the province, we become a little bit more populated, but we have to, Alberta's not the biggest province in Canada, but it's still a fairly large geography given what we've got. And I think government in general and healthcare specifically, we have so many stakeholders and so many people who are able to put their hand up and say that they have a perspective, they have something that says that they have should have some influence or something like that. And then the last thing from a healthcare perspective that's really difficult in the business transformation, I always say to my team, follow the money. If you don't know how the money flows, then you're missing probably your biggest set of stakeholders, because my normal golden rule is he who has the gold makes the rules. And so following the money in healthcare is fairly complicated, but it's proven to be quite useful, I know, in my career with AHS, because it really does help drive a foundational motivator of who you should be talking to and seeing which people may not be at the table when you're looking at business transformation risks of an organization of AHS's size. And so I've had that good fortune in my previous career at Fujitsu Consulting and to actually have done many post-merger analysis and consulting opportunities. Certainly joining Alberta Health Services, it's one of the first times I've had to live my recommendations. So moving from a consultant into the client side has been quite an interesting journey, to be sure. The first thing that we did in 2010 when I joined that was in progress was identity access management. It was one of those ones that was like, if we can't get and know all of the people who are appropriate folks that we can authenticate them and get them the right building access and start to get a handle on system access and all that stuff. That was our maniacal focus for a remarkably long time, because as you might imagine, post-merger situation of 8 former health entities and 4 geographies and then adding EMS onto us after the fact was quite remarkable. It was just crazy. And so we spent a lot of time both on identity access management and the master data that underlies that behind the scenes. So that was a fairly interesting thing. And then for the next few years, we started a process to do back office rationalization. So we standardized our finance system first, back to the golden rule, because finance, they don't have the goal, but they tell people whether they've got any or not. And that was reasonably tightly coupled with our procurement system. So our supply chain management system and our finance system we both standardized them provincially. And I would say that I want to give a shout out to our supply chain folks within AHS. They probably are the most under-recognized people on what they've actually done to drive value for us as an organization. They've been phenomenal. The biggest call out I would say is their prescience during COVID. They had an order of PPE, extra order of PPE in the system in December before the March official pandemic announcement. And we were in a good situation at that point in time, both because we actually have disaster recovery emergency stores, but we also had that extra inventory that we were able to share with some of our other provinces. And so I think, like I say, a lot of the focus in healthcare is always and appropriately on care provision and patients. But our back office rationalization and supply chain management efficiencies that we've achieved, I think, are really good. But the case study that I want to talk to you about, though, is what I call our front office rationalization, which is actually transitioning the way that we actually deliver care. And so, I don't know if everybody here or most of the audience here is in the government, but certainly I've discovered, having come from upstream oil and gas exploration where decisions are made in minutes, to a large organization like Alberta Health Services, I've had to get used to a longer and different planning horizon. And so I've been very fortunate to be part of this journey since the beginning. I helped coordinate and submit the original business case that was developed and submitted. And I also participated with many people on how we went out to the marketplace, submitted requests for proposals, and then started to configure the program, which we call Connect. And the original business case was actually titled Provincial Information System, a Catalyst for Change. Because as you can imagine, if you do any post-merger situation, I don't care which industry you're in, we have a divergence of, we have application portfolio, depending on who counted. Let's just say there was in the thousands. We have in the thousands of applications, whether it's one, closer to 2,000 maybe than 1,000, it depends on how you want to count. But I feel like IT is typically a reflection of the business in and of itself. And so we ended up having an application diversity because we had a business clinical practice diversity. And that varied by region. Calgary zone had been a little bit more doing regional kind of initiatives. Edmonton zone was more facility based, and rural zone, honestly, they learned how to cooperate and collaborate with each other because they have to, right? In a rural zone, you have to be able to work together across multiple municipalities to be able to get things done. And so, you have this fairly large inconsistency of clinical practice and business operations or clinical operations. And we had to go through as part of the change management of planning to go to the marketplace and going out for the proposals, we had to start that catalyst for change conversation from the very beginning, right? And at the time, it was a fairly IT led initiative in the early stages. But as we were planning to go to the marketplace in the 2015-16 is when our clinical leadership took the lead of actually driving the change. And that would be my key here. It's a business change. If we can't convince the leadership that they're going to stand up and say, this is a change that's good for our patients, it's a change that's good for our providers, it's a change that's good for everybody, and they're going to stick to their guns on the change, I don't care how innovative your technology is, it's going to be a really, really difficult time. So we went to the marketplace and we went live in November 2019, just in time for what. So it's been quite the journey. But let me talk about it from an enterprise architecture perspective. This is the model that we used to communicate to the senior audience in that AHS was a massive organization. And we were writing our business case at the very top level here. We're writing it for everybody within AHS and all of our stakeholders and everybody like that. But I needed a way to be able to drill down into segment architecture. So we actually developed and had models for surgery, emergency department, laboratory services, HR. Well, HR wasn't impacted, but we had those models, right? And so this representation here is actually, I lifted off the United States Federal Enterprise Architecture Framework. But I added one thing to the model for AHS, and that is value. So you've got a level of how you're documenting and describing your architecture, so for me, it would be AHS, then I might go down to emergency medical services, and then I might look at a solution architecture for emergency response versus interfacility transport, right? So it's a mechanism for me to go and understand our business model at an appropriate level of detail so that I can actually document things as I do. And typically what I find is whether you use balanced scorecard in healthcare, there's triple aim or quadruple aim. Quadruple aim is what most provinces in the federal government have adopted. You actually have to understand the business model. So as an AHS, I have business models within business models. So the lab business model is radically different than the emergency medical services business model. And so I have to understand what the business model is typically at this segment, what the United States government calls a segment architecture, we call it domain architecture. And then this is a solution architecture, but I call it a specialty in healthcare. And so this is kind of if you don't understand the context of your architecture deliverables, which is what this framework is for on the left-hand side, then if I don't understand the value, then I missed the mark. So this was a real key critical point. It came out in our business case around, most of what was in the business case was tangible, where we thought we could actually do some things, which we've realized where now when somebody tries to order a lab test and we know that it's been ordered in a reasonable time frame, and that varies by lab test, we automatically send the provider who tries to order that new lab test the same lab result and say, is this good enough? Do you really need to order this, or can you just use the one that's there? And the same, we're hoping that that's going to save us many a lot of money, or it won't save us money in healthcare. That's a misnomer. It won't save us money, but it will reduce our wait times and stop us from doing repeated, and then it will reduce waste, essentially. I would say in general, that's what we end up doing. It's not that we don't have an overwhelming demand for healthcare, but can we reduce the waste so that we can deliver care for more people with the same level of quality? So the business team came up with a number of principles. And boy, oh boy, did we have to use these principles. If you're going to do transformation, and it's true business transformation, not just technology transformation, you need your principles. Certainly putting patients and family first was good. Despite the timeline I just showed you, we were actually having to make some fairly big decisions on a really accelerated timeline for where people were used to. My biggest and most fun one that I've used, and I think this should be a one for anybody, it doesn't matter whether it's healthcare or otherwise, is avoid unhelpful variation. Everybody's special. Everybody's got their particular way that they do things. I don't want to, on the one hand, you don't want to diminish that, but it's avoid the unhelpful variation, right? It's almost unmanageable if everybody gets to do whatever they want, right? So there's an interesting gap there, and the hard part with a lot of technologies, especially when we're buying what we purchased, which was a clinical information system, which is essentially an ERP for front office for doing care, is if you have to use the business processes that are baked into that system, right? So we had to try and get people to say, don't try and remodel what you currently do. Let's look at the target state and then modify that as we went along. So these were our 10 principles that we used and reused, and it was very nice to see leadership adopting these mantras to the fullest extent that we did. I don't think we could have been successful if we didn't actually take these principles and have them. See many situations where we take principles and put them out there and nobody looks at them again. It was like a ticky box, right? Okay, we got our principles, moving on. We lived these. We live these. And maybe we had too many, but this was very, very important to our success. And so we did an enterprise architecture analysis based on what I just showed you. We created, for each of the segments, we created mission model cabinets as we used the Porter healthcare value chain as an organizational change management initiative to bring people together, to show them that what they were doing in one part of the province versus what was happening in another part of the province really wasn't that different. You were just maybe calling it different things. We created a business capability catalog for any business architects in the crowd, which is proving to be useful, more and more useful over time. And the biggest thing we had to have is an application catalog, so that we knew where applications were being used across the province and by specialty, and be able to understand that. Because if you're going to roll out a provincial clinical information system that's displacing 300, 400, 500 applications, then we had to, you have to know where those applications are and plan for their transition, because this was a massive exercise, to be sure. And so this was the biggest part of what we had to do, is we had to do an application portfolio analysis, sorry, I'll go back. Yeah, sorry, I see the Q&A. I'm just going to go back. Oops. So the question was, what's been our approach to generate segment capabilities versus the enterprise ones? There's only one enterprise capability catalog, period. And so a segment is going to have specialties, and we map business capabilities at the value stream level, and then you have value streams associated with each segment. And so the mapping to connect them together is at the value stream level. Because if you try to do just a mapping between business capability and segment, which you can do, and we did do, just to show them at a high level what that looked like, that gives you some information. But I find in general, people, when they're just looking at the business capability catalog, they miss this value dimension. So that's really the most important part. So value stream is the way that we connect the dots. You link a value stream to a segment, which is obviously to the enterprise architecture, and the value stream maps the capabilities. There you go. So that's what we did. Application portfolio analysis. This was a massive amount of effort, and we had to do it very rapidly. And so we had a paradigm that you can see here. The architecture team ran this. It was quite a lot of fun when you go in, especially to areas where they had developed an application that completely mirrored their existing business practices and they didn't want to change. And we had to come in and say, nope, sorry, that's being replaced. Normal Pareto rule applied here. 80% of the applications we were able to say, yep, that's going to get replaced. It's a clinical documentation tool, replaced. There's a number that were also easy to say, yep, that's not going to get, there's no way that'll get replaced by the new product. So go from there. We had some new stuff that we had to add on to make sure our new product would work. And so we had to spend a fair amount of our time there. And the hard part, this is not a once and done exercise. We still continue to do this. I'm still doing this now. You'll find out new things that either our product vendor Epic will release, or we get a better understanding of what's going on. Or sometimes we'll even get clinicians coming to us and saying, yeah, now that we've been using the new system, we really don't want to use this other one anymore. What can we do? So I think application portfolio analysis is an ongoing thing. This paradigm worked for us. Sometimes, though, I was talking to one of our service owners. We have an application that's on very, very, very old technology that we had to keep limping along until this last May. We were doing a lot to try and keep that thing running because we didn't want to do any. We couldn't upgrade it or anything. So it's a lot of fun. Question from the crowd, question from Andy. You spoke about multiple stakeholders involved in the architecture process working together based on principles. How do you hold people accountable and avoid the risk of creating a fragmented? Okay, that's a really important question.
Alec, Bob Wiseman, sorry. I really would like you to get through this presentation.
Oh, sure. Okay.
I'll handle the Q&A at the end.
Okay.
And people, if you're going to submit a question, please make it concise. Thank you.
Okay. Sorry. So the last piece of this, and I've got, I think, 6 minutes. You would not imagine, or you could have probably imagined that when we're going through the information infrastructure modernization that was required here, we went from 10% of our buildings having ubiquitous Wi-Fi throughout to now 100% of our buildings having Wi-Fi throughout. We now have clinical data terminals in every single exam room and every single patient room. Our medical device integration had to be stepped up a notch. Our network infrastructure had to be expanded to be able to put in redundancy through the entire province, through all of our locations. And we had to make sure that we had enough bandwidth to affect all of this. And then our data centers, we had to obviously go to a fairly robust model to make sure that we had as best business continuity as possible. And this all had to happen 2 years ahead of when we were actually going to land. So our poor facilities people, because some of our buildings are rather old, and so trying to actually install Wi-Fi hotspots in buildings that were sometimes 50, 60, 70 years old was requiring our facilities people to do some really crazy things. And so when you think about digital transformation, we just had some foundational things of just getting Wi-Fi out to as much of our locations as we could, let alone, we probably doubled our non-medical device footprint in the province. And now medical devices, in the past, we could rely on just kind of serial, like really remarkably serial RS-232 connections to computers. Now we're getting into usually network-based, not as much wireless as per se, very, very specific use case of that. But this infrastructure modernization, the team that handled that, like I said, to be out in front of it, and because this is our release schedule. So this is our Connect Care launch. This is available on the Alberta Health Services website. It was just updated on June 7th. So I can remember I told you that we launched November 3rd, 2019. In March 2020 is when the pandemic hit, and you can see that we actually did a launch, a small launch, because the groups here basically said at the time, the disruption to our clinical practice is outweighed by the clinical benefit for the patients going through this. So we just, in this last May, we just did launch 6. That means that now across Alberta, all but 2 hospitals are on the common clinical information system, as well as our lab systems. And so that is a massive milestone for us. Launch 7, 8, 9 are going to be targeted a lot more at our continuing care facilities, which is actually a disproportionate number of the beds that we have in the province as opposed to acute care beds. We're also doing our population public health folks, which includes communicable disease control, and there's some additional minor pharmacy and other things coming along here. So we're still a year and a half away to being finished what was originally planned in the scope. We're actively planning for what we're euphemistically calling Launch X. Launch X is undetermined, where other people we hope will be added to the Connect Care landscape, and going in from there. So this was so now think about this. So now we're trying to manage and understand. We can't go big bang, obviously. We just can't go big bang. I couldn't train everybody. We couldn't just turn it on. It was good. So we're doing 9 launches. It was originally over 3 years. Now it's over 5 years. We need to know where the applications are. We need to know the interim states for all those applications. We need to create interim state workflows, all that kind of fun stuff. And we ended up we created our own architecture tooling, which we use, called master architecture data, which actually built all of these relationships between locations and departments when they're going live, application mappings to departments. And we were able to, whenever something happened, like, big things like COVID, which pushed everything out, or small things where this location says they need more time and they want to move over here, we were able to have a centralized repository and portal where everybody knew who was going live when, and they were able to understand their own impact. It's just been a legit, like, from now on, the launch 5 is our biggest launch, but from launch 6 on, every single launch after this will be about half the size from the number of users as the previous launch. So we kind of went one big campus facility here, then we did a small launch, and we did this one was regular, and then we peaked, and now we're going back down the other side. And so, digital transformation is interesting because it depends on what it is. I've promised before I retire in the next 7 to 10 years that I'd like to get rid of fax machines out of the healthcare system. I'm not sure I'm going to actually succeed, to be honest. But it is relative. Like, my daughter was actually a graduate nurse, and she was on location at the University of Alberta when we went live. And at the beginning of her shift, she was using. She had a binder that was in a sleeve at the bottom of the patient's bed that she opened up to do her clinical documentation and see her history. And at the end of her shift, she was scanning the medications on a mobile device to do the medication reconciliation, right? Which was a massive, obviously, business practice transformation, technology transformation. Not everybody had that big a gap, but that's certainly there. And you have to stay focused on the business transformation. I think the nicest thing about all of this is that the clinicians all got it, right? It doesn't take much for the clinician to say, gee, more and better and current and up-to-date patient information. Yes, I can get my head around that. Now, there's always going to be people who don't like change. That's going to be true no matter what. But I think when everybody, everybody kind of got the reason for the business transformation, and there wasn't. I think there might be some questions on how we were doing it, but there wasn't a question for need along the way. And the last one was just be ready for speed bumps along the way. I think that's been the biggest thing where we're, think about some of the curveballs that we've got thrown at us. And we were able to form what I think the industry calls tiger teams, where we would, bring all the relevant stakeholders into a room. We'd figure it out. We'd write the decision request. We'd get it. We'd socialize it within the key stakeholders, and then depending on the size of the decision that had to be made, it went up. It had to get approved. But we had to make sure that we could do those kinds of things with speed and prioritize along the way using the principles, which was good. So back to what I said at the beginning, my key messages for you all. Start with a business transformation, right? It's not a digital transformation. And for us, we wanted to have a patient experience and a clinician experience that had the right information at the right time in the right place for our people to provide care. And we understood our business context. I think that's we knew where we were. We knew some of the challenges we had. That we, the hard part about healthcare is it usually is in the press, especially during COVID. And so we took our understanding of business context, but made sure that it was localized, right? I can't talk about AHS. I got to go down to the domain, and sometimes I've even got to go down to the segment level to be able to put myself in the right business context. And you can see the time dimension. I still have to do a 3-year plan whenever I'm looking at any kind of thing, even outside of Connect Care, because there's so many moving pieces that you have to be aware of. Sometimes that's the vendor, like Microsoft, or somebody else telling us what we should or shouldn't be doing. And sometimes it's, business initiatives that are going on. So we have to, time dimension is always top of my mind. I've tried my best to not look more than 3 years out, because my crystal ball gets really fuzzy at 3 years out. But more often than not, we are trying our best to be agile where we can. That can be difficult because of the transparency we need for our procurement processes. One of the interesting things we're looking at having a much better way of doing our digital transformation initiatives is actually, as you might imagine, we're part of a lot of research studies, and there's a fair amount of rigor around research studies to make sure that we're not doing the right things by the patients and following a lot of the rules that are there. So we're actually pushing a lot of our innovation to try and actually be part of a research study where it can impact patient care, because that gets us the evidence we need following the good practice that our innovation team and the research folks have. And that actually allows us to be agile, because by design, most of our research studies are quite small. I wouldn't say they're agile to the true extent of agile, but at least from a AHS enterprise perspective, they're agile. And so that's what I would say is we've gone through a massive change that's still not done, but from a hospital perspective is almost done, and it's been quite the wild ride. So I think I'm within my time limit. Robert?
Yeah. Okay. Sorry. I switched. I'm starting to talk, but it doesn't help when you're muted. Okay. Well, listen, Alec, that was a great presentation. And just for the international viewers, healthcare in Canada is a government responsibility. Okay. And it's not a federal government responsibility. It's a responsibility of 10 provinces with some help from the feds. And right now, having the healthcare costs that are exacted by business architecture that's arcane, that is obsolete, are just stupendous. We need more money to spend on practitioners, people that give the services and do the research. We don't need more money for more bureaucracies. So I think the work that Alec's doing and his conclusions are spot on. And I think it's something just to be aware of. Don't just throw technology at the problem. Transform the business, and then what happens is enable it through technology. And that's at the heart of digital transformation. Okay, for that. That was an excellent presentation. Thanks, Alec. I'll just quickly, and I want to make sure that from you understand a bit of the architecture speak. Segment is just a subset of the organization. Okay, can be a line of business or whatever. You basically, so you have stuff that's done at the Alberta Health Services, and then you might have certain regions and everything else that are basically doing certain other systems internally. And one of the questions we have actually is, how do you coordinate what you're doing at the AHS level? I won't ask about the feds, at the Alberta Health Systems level, and what you're doing in your business segments or regions or whatever that are doing their thing.
Yeah, and this is where you're having an enterprise architecture that allows you to go down in these levels is terribly important, because let's pick on emergency medical services. We had a recent one where we wanted our computer-aided dispatchers who are receiving 911 calls to potentially be able to hand off a call to our 811 HealthLink nurse triage team. And I was able to say, okay, well, that's a reasonably straightforward. I've got a value stream for emergency dispatch, and I got a value stream for nurse triage. I need to connect those dots. I have to update 5 applications. So you allow your business architecture then to dictate how you manage the governance around that and how you do your analysis, right? So you're having a good enterprise architecture, business enterprise architecture allows you to then make sure you're engaging the right stakeholders. And then those stakeholders, I can then drill down into their application portfolio and then make those connections and go from there. And in that situation, we were able to deflect, and because 98% of all of our calls to from 911 get an ambulance dispatch, we've been able to deflect 5% of those calls, at least in the initial trials, so that the nurse on a phone was able to resolve the medical issues. So that's pretty big for us.
Oh, it's significant. So I think that's no, that's well done. We have another question. Is simply saying is, you know, you need to get your business or DT organized. Did you have to convince people that they have to change the way business is done, or was there buy-in already from the executives? And do you have any hints as to how to do that?
I honestly would say that we have more demand from the business to try and modernize things than we can handle. And so the unfortunate part is we have to go up to our business operations people and make them prioritize between our investments. And so the biggest thing that actually happened within Connect Care that we hadn't had before is that they actually created what's called the Connect Care Decision Council, or sorry, CC Executive Committee. And they actually had to approve not just the decisions that affected our program, the big program, they actually had to approve things that are outside the program, because they're saying, we're spending a lot of money on this transformation initiative and it's got the primacy of focus. And so while these other things might be nice, focus, right? So we actually have a fairly elaborate governance structure that we're actually having to rationalize now that our major hospitals are down, which are arguably our most complex business areas. As we rationalize, now that we're going to some more of an operational mode, we're having to rationalize. We had over 100 governance committees, and those are getting rationalized down. We're hoping to about 50-ish. Probably going to be more than that, but.
Oh, that's great. So essentially what happens is people are already open to transforming the business.
I would say more often than not. The hardest part is when you actually have competing people, because you've got somebody in one region trying to do the same thing as somebody in another region, and actually getting them to align there.
Sort of herding the cats analogy.
Yeah, well, but that's part of it as well. I call enterprise architecture slab and silo busters, right? So if we can connect the dots between people trying to do similar things, and they may not even see themselves as similar, because a lot of times healthcare looks at themselves in this very specialized way, right? So if I'm a surgeon or a subset of surgery, I may not think that I'm doing the same thing as another specialty in another area. So that's where I think having a good enterprise and business architecture and connecting some of those dots allows you to connect dots that people wouldn't otherwise see.
So that was a way that you were able to bring along regions that might have, do the regions, is there one measure for degree of readiness, or is it basically separated within the various regions? Because Alberta is large.
Yeah, the regions, so think of it this way, the regions have to exist in their primary organizational structure, or they have been. I think that's starting to change. Because you have to manage people and logistics at a regional level. Like you have to do staffing at a hospital level, right? And so and to be fair, you also have to recognize that the way you staff a rural hospital, where the emergency department might have a doorbell on it, so the person on unit 2 can come down the stairs and answer the door, is obviously very different than a major urban hospital that has specializations. Like, you think if you go into the Children's Hospital in Calgary, they see so many broken bones. They have a broken bones speed lane. Right, they've got a process to put those kids through that process. Like, it's amazing, and I know, because one of my kids had to go through that. And so I think you've got to recognize the regional diversity and take those into. But it's back to no unhelpful variance. They are special because they are special, and they don't vary where it doesn't have to be varied. And that takes some good rigorous thinking. And our executive teams sticking by their guns and making sure that they themselves are staying accountable to their principles. And I'll give our business and clinical operation leaders, they were very thoughtful. They took this as you might imagine, very, very seriously. IT, on the other hand, is somewhat easy in retrospect because they were able to make a lot of the good decisions with the right rationale. We weren't the ones having to hold their toes to the fire.
Okay, well, that's very insightful. Now, a bit more of a technical question. Do you have have you automated your application portfolio management?
No, we didn't really feel we had a need for that. We do have our CMDB, which is an authoritative source of all the IT managed applications.
That's a good CMDB is
configuration management database. It captured all of the applications that were managed by our IT resources. We actually had to complement that with another application inventory list that the architects maintained for business applications that were managed by the business, and sometimes external applications. And so we didn't, from a portfolio management perspective, it was pretty easy for us. Is it going to be replaced or not? So I don't need a whole system to say, yes, it's going to be replaced. Let me back up. We did have some where it's under investigation. We had keep, partial replace, already decommissioned because we found stuff that had already gone. Anyway, we had 5 attributes that we put on our application portfolio, and those are exposed through our portal so everybody could see it. And then we linked all the applications for each of our domain segments. We call them segments, but I call them domains and specialties. So I can go down to EMS and I can see all the applications in their portfolio. I can go over to public health and see there. So everybody was able to see all of the applications from their particular business context. So is that a tool? Sure, it's a tool, but it's SharePoint, honestly. That's what we use.
Whatever works. That's the main thing. Well, listen, Alec, thank you ever so much for basically taking the time out to present this. This has been very fascinating. And I think for most people, healthcare is a wicked problem. This is not easy to resolve. And they're going to have to. We just can't afford to provide the services necessary to an aging population. And at the same time, spend the same amount of money on bureaucracy. And there is bureaucracy involved in that. But anyways, thank you very much for opening our eyes on that and presenting a structured way to analyze and moving forward. Yep. Not just throwing technology at the problem, but changing the way that the healthcare is delivered in this particular case.
Perfect. Well, have a great rest of your conference. Thank you very much.
Okay. You're very welcome. And now I would like to, just before I stop and stop the recording, I'd like to basically recommend that everybody's going to have a coffee break. And at 14:30, 2:30 afternoon, what we're going to do is we're going to have 3 more screen sessions. We've got Dr. Pavel Harabe from and he'll be talking about the Czech Republic and what happens is business and technology collaboration. And this will follow in the theme of what Alec started already before, and that's in stream 1. And that'll be followed by Guy Pearce and a gentleman from Global Affairs Canada. And we'll be talking about e-government in Rwanda and how they basically move forward. And think about the Ukrainian, for those of you who attended the Ukrainian presentation by Valeria, and also the GovStack and the GovTech. And then you'll be able to put the Rwanda success story in context. In stream 2, we have the Defense Digital Literacy Initiative. Colonel will basically give us an overview of how they're educating their staff. And when we talk about digital literacy, a lot of it is culture transformation. Okay, for that. And then afterwards, we have a session by Dr. Danica Marsden, who's the principal quantum data scientist over at the Bank of Canada. And it'll be a Q&A session. So I recommend people, especially of the female persuasion, is if you have questions about women in the science, technology, engineering, and mathematics side, and you want to know how an individual has not only gone into it, but absolutely thrived in that environment, I would really recommend that you listen to her and ask her questions. She's there to help. And I know there's a lot of people, grad students and students listening, and also just plain individuals that want to advance their career. Then what happens is you can ask her how she's basically made her career choices and she might be able to give you some nuggets of advice that are very valuable. And in the third stream, we're going to start off with Dr. Daniel Amiot, and he's going to be talking about a graduate program for digital transformation and innovation. And that's going to be followed by Murray Cronick, and he's from the Telfer School of Management. And he's going to be talking about digital transformation is not about transformation, it's about getting the results, which again is a very business-oriented stream. So I look forward, hopefully that you're enjoying the conference and everything is going well. And now I will stop the recording and let you get a cup of coffee so you can attend the last two sessions. Okay, thank you very much. Take care, everybody.